CE Direct course called Nurse's Guide to Pain Management. It was actually quite interesting. If you could please do the pre-test and then the post-test, as Anne asked us to do. And hopefully this shouldn't take too long. All right. So the objectives of this course were to understand the scope of under and untreated pain in our patients, what the Joint Commission has done to correct the situation, myths and misconceptions regarding pain assessment and treatment, learn how to do proper pain assessments and techniques, and also about analgesics, what they call equi-analgesics, and non-pharmaceutical relief measures. So it initially starts talking about untreated and undertreated pain. And I didn't realize how prevalent it was. The statistics say 76 million Americans live with chronic pain. That's a lot of people. And the ones, of course, that are most affected, not surprisingly, are the ethnic minorities, elderly, children, homeless, mentally ill, and current or former substance abusers. There's not much surprise there. They're talking about the physical and functional effects, which is something that we see a lot of. You know, people who can't do their ADLs, whether it's shopping or taking a shower because they're in so much pain. But they also can't participate in getting better because they're in pain. So it's kind of a catch-22. Disrupts their sleep, it decreases their appetite. They have increased falls either due to pain itself or from the medications, making them unstable. And then if it gets bad enough, they end up being immobile, and that causes, bed sores, pneumonia, and all the way lead up to them dying because the root cause being the pain. Psychologically, there's a lot of problems as well, disruption of focus, concentration, and memory, which of course impacts us as nurses, because if we're trying to teach them something and they're wrapped up in their pain, they're not going to pay attention. So then they don't even have the skills to help themselves. Spiritual-wise, increased sense of suffering, especially they may feel that they're being punished for something in their life and lose their faith in God or whatever higher power they believe in, and that can also significantly increase their suffering. Financial, of course, we already know the cost of people coming into the ERs for pain, but also the lost hours of work, and then for caregivers who injure themselves taking care of people with pain, so then they become another category that adds to this whole problem. So in order to start correcting this, the Joint Commission started looking into it. There have been guidelines, practice guidelines, since like the 80s, but most of them weren't being followed. Pain specialists do believe that most cancer patients can get satisfactory relief from pain, but it's not being met. So in 2000, the Joint Commission released some revised standards on how to take care of pain assessments and the management of it. They are doing surveys of institutions to check whether these standards are being implemented, and if not, these institutions can lose their accreditation. So it has a pretty major impact on them. We, of course, play a huge role in this, in being the ones who primarily do the pain assessments and medicating the patient, as well as contributing to other facets of that. Some of the issues that have led to under and untreated pain, we're well aware of. Some of the barriers in that we are not allowed to titrate pain medications. We always have to have an order, so there's a delay in getting that care to the patient. There are social and cultural beliefs where patients do not want to be seen weak, especially men, so they are very stoic and don't tell us about the pain they're having. One that really surprised me, but obviously is significant enough since they listed, is the family dynamics that some people enjoy, their family members suffering. So I was quite floored by that one. And of course the lack of education, where people don't necessarily know exactly how to do the assessments. Also the whole issue with addiction, sedation, and hastening of death. Of course, we're all familiar with those, where everybody's like, oh my goodness, we can't give them any more. There's also on the doctor's end, some of them may fear regulatory reprisals for over-medicating, and then of course the whole abuse, people buying the stuff to sell or themselves using it for something other than pain relief, of course. So the Commission recommends pain committees, which pretty much includes a member of each of the healthcare teams, whether it's nurses, doctors, social workers, physio, all of those, to all contribute and assess the patient through the range of daily life. That the pain committees also help establish the patient's Bill of Rights, in the sense that every patient has the right to pain relief. The committees screen for pain in all of its facets, and that pain be considered a fifth vital signs. In fact, California actually has it as a law that it has to be charted along with your blood pressure and temperature. So they then also want to make sure that staff is competent in assessing the pain and managing it, establishing policies and procedures for this assessment, and big time, of course, accurate documentation of it. That we need to educate families so that they're aware of not just, oh, well, yeah, your pain needs to be controlled, but why the pain needs to be controlled so that they can continue to get better. That pain needs to be addressed all the way through their stay, as well as once they go home, of course, because otherwise they're just going to revert back and end up back in the hospital. And then, of course, assessing the outcomes of how well the current medication or a non-pharmacological scheme is working. So when it comes to the pain assessment, myths and misconceptions, first of all, they define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So once you start looking at that, it's important part of the assessment is that you accept it belongs to the patient. Whatever they say it is, it is. So they consider self-report the most reliable indicator of pain. The physiological symptoms, they may be there when the patient initially feels this pain, but after a while, if there's a continual pain and becomes chronic, those symptoms will revert to normal. It's kind of a tolerance level where they don't realize, or the body just sort of reverts back, goes, oh, well, we're used to this. So that may not be an indicator of having pain. And also the other big thing is that not all pain has an identifiable source. So just because we can't find a lesion or an abscess or a broken bone, it doesn't mean that the pain isn't there. When they talk about pain threshold, it's when a stimuli becomes painful. And everybody's very different. And even though a procedure, two patients may have the same procedure, they may not perceive the pain the same. One may float through with no problem at all, and another one it'll be completely debilitated. So that's a large hurdle when it comes to objective pain assessment. Is we tend to have preconceived ideas of how we personally handle pain, how we've seen other people handle pain, and also your own biases of, especially like substance abuser. I think we all fall into that pitfall. So when they're talking about pain tolerance, it means the duration and intensity of pain a person is willing to endure, and that's where establishing the level of pain for comfort, and not just being able to just sit there and tolerate the pain, but being able to do the deep breathing, the ambulation that we need them to do, especially post-op, in order for them to get better. So we need to establish a baseline for this patient so that we can see where they're at on this continuum and then treat it accordingly. Another misconception that I fell into as well is that we tend to think, oh, the more pain they've experienced, the better they're able to tolerate it. It's actually the opposite, because they know how bad the pain can get and how hard it can be to catch up. So it increases their anxiety a lot more, which of course increases their pain level. So that was one that kind of surprised me, actually. So then techniques for assessment, the very popular one is this pain scale, which we use with most of our patients, but that depends on them being cognizant and being able to understand what we're talking about. The other one is the Baker-Wong FACES scale that is used a lot, especially with kids. Mind you, they have to be older than 3. And again, they have to be cognitively intact to be able to understand what you're asking them. They ended up making a revised scale of the Baker-Wong because the last picture, if you look at it, has crying on the face. And they determined that a lot of men would not pick this face because it would make them look weak for crying. So they've renewed this one and changed the face so that there are no tears on it. So they can do that. The other scale that we use a lot, especially with our intubated or obtunded patient, is the FLAC scale, which shows physical signs, whether they're grimacing, they're restless, that kind of stuff, to determine somewhat what their pain is. Then, of course, the quality of the pain, that helps us choose the treatment. If they're sore and stuff, we may go with anti-inflammatories versus an incisional pain where they might need narcotics. How long the pain has been there. The literature says that if a patient has more than 12 hours of pain per day, they should just be on a regular scheduled dose to keep them at a comfort level. If it's less than that, then they can probably get away with a PRN schedule where you medicate them as needed. Also, the manner of expression, of course, especially in nonverbal or young patients, if the family can tell you, well, when he's having pain, he does this, that would be very helpful. Reassessing is, of course, how well the intervention worked and how much relief the patient gets. That, again, comes where that threshold comes in, where we ask, have we met your goal of getting your pain down to a 3 or 4? And then that helps us determine whether or not we need to completely change the scale or not. Pain flow sheets are very good, especially in home health, where families can document the pain level that patients are experiencing and how much relief they get from the treatment plan. When we talk about analgesics, there are, of course, the opioids, which we use a lot of, as well as what they call the equine analgesics, the non-opioids. So opioids, big problem. People always worry about addiction. It's actually a very small percentage that have an addiction, and that's using it for other than pain relief. It's just a constant craving for this medication. Then, there, of course, physical dependence is different. It's a normal, expected physiological adaptation, and that commonly occurs when the patient has been taking opiates regularly, and that's where you see the physical withdrawal symptoms that are like flu-like when you stop a medication. Tolerance is characterized by any decrease of one or more effects of the opioid, whether it's the amount of pain relief they get or side effects. Now, the one side effect that they never build tolerance to, unfortunately, is constipation. Usually the side effects of narcs stabilize after a few weeks. They will continue whether the medication is given IV or PO, but once you change to a different narcotic, that tolerance may not be there anymore, so you have to take that into consideration. With the narcotics, there is really no ceiling. It is pretty much you monitor and treat to effect, and they say not to worry so much about the dose. As long as you're monitoring for respiratory depression and sedation, then you can keep going up. With non-opioids, like the Tylenols and NSAIDs, there is a ceiling effect, meaning that more is not better. Once you reach a certain dose, it doesn't matter because it's not going to relieve any more, but can start causing damage to tissue as well. Then we have the adjuvant analgesics, and for neuropathic pain, there's several, like the antidepressants, anticonvulsants, local, and methadone is also one good for neuropathic pain. What they're talking about, the multimodal approach, of course, is doing your non-pharmacological treatments and then adding NSAIDs and Tylenols as needed, and if it gets bad enough, adding the opioids. Using all three of those in a pain treatment plan usually meets the needs best. When it comes to non-pharmacological, of course, no drug relief. Many that we have mind and body that works with that is the distraction, relaxation, cutaneous stimulation, heat and cold. I didn't realize we tend to sort of reach for heat, but it's actually cold that treats pain better because it decreases inflammation and the spasms. Moist heat, if you're going to do it, is better because otherwise, and cold, I guess, not necessarily, but with heat, especially moist is better because otherwise it draws the oils out and then can cause skin issues. Massage is a big one because it helps relax people, but it also improves circulation. So in trying to combine all of those in a timely manner, reassessing where the patients are at with their pain relief and listening to them, telling us what is working, what isn't working, and how to improve all of this, that we establish a proper pain management plan for each patient, which, as from the previous statistics, is obviously very important to all of us. So this is the end of the presentation. If you can do the post test and just leave them in the envelope in the break room, I will see you guys later. Thanks for listening. Bye.